I'm Dr. John Rumberger. I'm a cardiologist and medical director. I'm also a former professor of medicine at the Mayo Clinic, and I'm currently a clinical professor of medicine at The Ohio State University. We're going to discuss today how I read coronary and cardiac CTA. My desire today is to actually teach you how to do this in an efficient, organized manner so that you can complete the review and evaluation, including report generation, in what I call the 10-minute rule. The 10-minute rule means that we want to start and end the session roughly in that time period. We're going to discuss 3 cases today. The first case is going to be a relatively simple anatomy to give you an idea of how we manipulate the images and how we display them. The second is to provide you with a little bit more typical type of pathology that we will see in our referrals. And finally, the third one will be a more complicated anatomy that requires a bit more detailed evaluation using the workstation. So let's begin with the first case. To demonstrate these cases, I'm going to be using the TARE Recon Aquarius workstation. The first thing I do is take a look at the studies to be sure that they have appropriate contrast opacification and that the images have been registered properly. Here's an example of how I quickly go through the original two-dimensional source images by looking at them as I go down, making sure that the coronaries are opacified, and appreciating the fact that it's important that the contrast has gotten all the way to the bottom. This is a very good study with adequate registration of the images and excellent opacification. The next thing I'll do is to then look at this in a 4D mode, looking at ventricular function. Once the images are registered, I flip into a maximum intensity view, roughly getting an image that looks somewhat reminiscent of an apical 4 or 2-chamber view that we would obtain through two-dimensional echocardiography. This allows me to look at the ventricle as a whole, and then I'm able quickly to register the images and display them in a 4-dimensional format, looking at the ventricular function, interventricular septum, apex, and lateral wall. I can see that the ventricular function looks normal. The global ejection fraction certainly looks within the normal range. I will next then switch to a lateral view, which allows me to develop a modified short axis view beginning at the base of the heart, noting again the interventricular septum, inferior wall, and other aspects. And then I will move down the ventricle in thin sections, adjusting this to allow me to view the entire ventricle. Notice that the ventricular function is normal in all of the individual myocardial segments, and I can move down into the left ventricular apex and again view all of the images. So this global ventricular function is normal. The patient has a normal ventricular size. There is no left ventricular hypertrophy. I'm next ready to look at the coronary arteries. What I do is have several phases as demonstrated here. Each of these are acquired at a slightly different phase of the R to R interval. You need to appreciate the fact that certain phases of the cardiac cycle may display the left anterior descending very nicely, and at the same phase the right coronary artery may have a blur. So it's important to look at multiple phases. They are chosen by you and by the technologist. In this case, we have chosen images at the 65%, 70%, 75%, and 80% cardiac phase. I will load these also into the 4D module. Once these images are loaded, I begin by using the convenient templates that are positioned in the upper panel here. I tend to use 3 templates, the slab MIP and then 2 volume rendering techniques. I first start out by looking at the coronaries in a thin slab MIP. Now, before we begin the review, let's discuss a little bit about coronary anatomy. The important thing to appreciate that you're going to be navigating basically on the globe, and the coronary arteries can be found in your left hand. This is the coronary anatomy, where this is the left anterior descending, this is the circumflex artery, and this is the right coronary artery. The diagonal vessels come off in this direction, the marginal vessels off the circumflex come in this direction. So I'm going to be navigating the coronary arteries in a globe, basically on the heart. This allows me to manipulate and allows me to have an intelligent and very efficient way to look at the coronary arteries. The first place I begin is at the left main coronary artery. You need to do this again in an efficient fashion. It's important that you start and have a pattern. The pattern does not particularly matter. I start with the left main. I then review the left anterior descending. I then return to the left main and review the left circumflex and the marginal vessels. I then return to the root of the aorta, and I start at the right coronary and proceed all the way down to the posterior descending. So we're going to start out with the left main. What lies within focus within the navigational plane here is the left main. I will start by recording these images by capturing them, and they are displayed then on the final report. I'll do a foot view, and then I switch very conveniently to the A view, which allows me to have a general anterior view that also allows me to look at the left main coronary. Once I've captured these images, I'm now ready to proceed looking at the left anterior descending. You'll notice in this patient that there is some proximal coronary artery calcification in the beginning of the left anterior descending. On a general view here, this appears to be non-obstructive, but I may manipulate the image by going and rotating in a small plane, and then basically what I call twirling or rotating about this axis by using the controls that allow me to rotate around the coronary. You can see in this view that there is some mild calcified plaque and perhaps some very mild soft plaque, but the lumen is quite patent and there's no evidence of obstruction. I will take a capture of that and then proceed back to the foot view, where I'm going to look at the mid-left anterior descending. I manipulate so I'm in the center of the viewing plane here and look at the left anterior descending. I notice that the vessel goes along in this direction, so if I move the mouse in that direction, the remainder of the coronary artery comes into view, and I can manipulate down the vessel, moving down into various areas. Now, if there are some areas that I might be confused with, for instance this area, which is probably an area of myocardial bridging, I want to look at the various phases to be sure that I'm accurately displaying the images, and that's done by moving through the phases very quickly. Each of these represents individual phases, and you can see that the one that I used originally perhaps is not the optimal view, and that a view such as this is a little bit better. So now I can see that the left anterior descending all the way down to the apical regions is very smooth and looks normal all the way down to the distal portions. The left anterior descending then is reviewed. I'm going to return back now to the circumflex artery, again returning to the left main. I know that the circumflex generally falls in this direction, and I'm going to navigate on the globe by moving the mouse in that direction, and this brings out the circumflex artery. This is largely just one large obtuse marginal, and again some very early mild non-obstructive plaque in the proximal left circumflex. I would then register this by capturing a picture, and then I can manipulate down further into this obtuse marginal by centering and then moving out in this direction, looking at the rest of the obtuse marginal. That is very normal otherwise, and I can return back to the site. One of the things that's very important as you go about these is to establish the dominance of the coronary arteries. This left circumflex is non-dominant. I see nothing coming down in this region here that would suggest that it feeds a posterior descending. So the right coronary should be large and should perfuse the distal portions of the apical region of the heart. One of the very important areas that I think that is something that perhaps in catheterization we tend to under-evaluate, and that is the ostium of the right coronary artery. This provides an excellent view of the ostium of the right coronary. Again, I can page through the individual phases. You'll notice this particular one gives a relatively poor view of the right coronary ostium, while I have an excellent view with these two phases. So I'll stick with these views. I've got a relatively motion-free image here, proximal coronary artery, and I'll navigate again in that direction, bringing the right coronary into view. There also was one view that seems to work out very nicely, that's very nice for display, and I'll go to the proximal portion of the coronary, hit the lateral button, and then do a manipulation which involves moving the mouse to the right and down somewhat. And you can see here that I've got an entire view of the proximal, mid, and distal right coronary on a single imaging plane. I will capture that. I'm satisfied with that image, and I'm now able to move quickly down to the distal right coronary. I again always return to the F or foot view, and this allows me to look at these regions down here. I have the distal right coronary artery, and I have the posterior lateral branch, and then a portion of the posterior descending. Again, if I don't see the vessels exactly as well as I'd like, I'm going to page quickly through the individual views until I find one that's satisfactory. Once I've done this, I've completed my entire review of the coronary system, and this can be accomplished generally well within 10 minutes. While we're on the subject of looking at coronary anatomy, I want to demonstrate quickly two cases in terms of understanding the standardized, logical way to look at the coronary anatomy. Here's a demonstration here demonstrating the aortic root and the left main coronary artery. In a standardized fashion, I would begin to look at the left main, evaluate that from several views, and then proceed down the left anterior descending coronary artery. After I was completed with that, I would return back to the left main and proceed to navigate to the circumflex coronary artery, which should follow in this direction. As I proceed in this direction, there is no vessel. So first of all, there is no circumflex vessel. You need to appreciate that this common congenital abnormality actually involves something else. This is the takeoff of the right coronary artery, and as you can see here, there is a vessel coming off at this angle, which in fact is the left circumflex coronary artery. This then proceeds in the correct direction, in a logical way, demonstrating the obtuse marginals. This is a relatively benign anatomic congenital abnormality that does not require further intervention in the absence of any significant coronary disease. Now let me demonstrate another case. Again, we're here at the aortic root, and we're going to move down into a region that we would anticipate would be the left main coronary artery. And I notice a situation where I see a vessel or an opacification in this region, and then as I proceed down this direction, I can see that this becomes the left anterior descending. In this case, the left main coronary does not come off in the right situation, and in fact, as we go to the right coronary, which we can see coming off here with the right coronary ostium, you can notice that there is another vessel coming off right here, and this is the left main coronary artery arising from the right coronary artery and passing between the aortic root and the pulmonary artery. This is the so-called sudden death lesion. This patient, regardless of the degree of coronary obstruction on any other views, should be evaluated for the possibility of ischemia involving this direction. Okay, we've now gone over how to manipulate the images, how to look at the anatomy, how to navigate down the coronary arteries, and of course the most important thing we need to do is how do we look at pathology and how we then describe this information to our referring physicians. Let's start off with several examples. Here's an example right here of the left anterior descending, and as you can see right in the center of the vessel there is an area of dense calcification. On this initial view, you might have the opinion that this may be obstructive. One of the important things to appreciate is that this is truly a three-dimensional view, and I can manipulate the images along any angle that I wish to have. The other thing is this is being presented as a maximum intensity projection of a variable thickness, and you can thin down this or thicken it up depending on how you wish to go, or you can move to a multiplanar reformation that allows a more faithful reproduction of a thin slice. So you'll see right here in that same area where we have calcification, you can see that just slightly within that area there is clearly a patent lumen. The other way to take a look at this is to return to the maximum intensity projection and display the vessel somewhat horizontal and then rotate around this vessel until we're able to get another alternative oblique view. Again, you can see here that there is clearly a patent lumen, and there does not appear to be anything certainly above a 50% obstruction, and that this is an eccentric, largely calcified plaque, but non-obstructive coronary disease. Here's another example of a feature that we commonly see. You'll see here in the mid-left anterior descending a region that has relatively non-opacified area that looks like what we call soft plaque, associated with at least a patent lumen and reasonable flow beyond that point. However, it's important for us to get a better idea of this particular area and whether or not it in fact is obstructive. Again, what we can do is thin up or thicken up the maximum intensity projection. Sometimes that brings out features that can be a bit better understood. Or more commonly, what I will do is arrange this to be either again in a vertical or horizontal fashion, and then I wish to rotate about this axis. So as I move around here, you can see that that lumen is still remaining very ratty in character, and even though it is patent and you can see the vessel beyond the left anterior descending looks normal, this is highly complex plaque, largely soft and potentially unstable. So I would read this actually as a high likelihood of having focal obstructive disease with a soft plaque region. We can also look at another portion of the same heart by looking at the circumflex artery. In this particular example, you can see a combination of hard followed by soft plaque and a linear area of calcification. Let's look at this first area approximately here. I will make this somewhat horizontal, and I wish to again rotate about this axis to look at that particular region. You can see here as you follow this that this circumflex artery is patent, and in fact at least up to this point, if you were looking at the luminogram, that is the coronary arteriogram, you might actually say that this patient has no disease, or it looks relatively normal. In fact, with CT, we're able to appreciate the full thickness of the coronary arteries, and this patient still has relatively severe, complex plaque, but it is non-obstructive. In summary, we have looked at the use of an advanced computer workstation and the variable tools that are available for manipulation of the coronary and cardiac images. I've also demonstrated a methodology of efficient and standardized review of the coronary anatomy. Finally, we have discussed the application and review of various coronary pathologies, including hard, soft, and complex plaque. It's important for you to appreciate that your speed of using the workstation will improve as your experience on the computer expands. Very soon you'll be able to follow my magical 10-minute rule. Thank you for your attention.